Now, this one I think can be a bit of a challenge for people. Do throw in what you think it is, and in the meantime, I'll talk my way through it as well, so that we can sort of work through it. Because I want you guys, anyone who comes to this, be able to sort of work through the problem rather than me just give you the answers. Because I don't think giving the answers is the way forward when it comes to teaching. And for those of you that have come to my teaching, hopefully you walk away thinking not only do I know the answer, I know how I can get myself to that answer. So no answers coming in just yet. So okay, so what have we got here? We've got a adult patient. Okay, and we can see nothing grossly abnormal in the beginning. So I've always got these check areas. For those that don't know, they're going to be the lung apices. I always look at the costophrenic angles as well. And then I also, then I'll also have a look at the heart as well, just to make sure there's nothing behind the heart. So there's nothing behind the heart from what I can see. If anyone can see anything, do let me know. So someone said bilateral axillary masses. So that's a very interesting thing to think about. Sorry, that's not me giving a laughing emoji. I am taking it seriously. So you're thinking around these areas and these areas, right? It's not a bad shout. I mean, I would say maybe possibly, but you have to also understand that, people can have skin folds. I think that's a pretty decent way to say it. So you can have skin folds, it can be all sorts of things. So I wouldn't necessarily jump towards that, especially in the context of maybe something else going on. So then have a look at the mediastinum. I always look at the mediastinum just to make sure there's no secondary sort of film-like density along there, because I have seen it where it can be very, very thin, and that's going to be something like pneumomediastinum. So no pneumomediastinum from what I can see. And then, a few people have got it. That's good. So then also look at the ribs as well. Just make sure there's no obvious fracture. Now, I don't know if people do this, but I really do zoom in and look at the lateral aspects of the ribs, because sometimes the angle means that you just slightly miss that the rib fracture that can exist. And actually, sometimes it is worth just sort of just spinning that the ribs around. And I don't know what it is, but maybe eyes are just better at looking at linear curves on a kind of so superior to inferior basis or something, but that sometimes does help looking for abnormalities when it comes to the ribs. But here, I don't think we can see any rib problems, and the humeri look okay. Sometimes you get some avascular necrosis, can't see anything abnormal there. No fractures. Clavicles can sometimes be missing as well, and the lung apices are completely clear. But yeah, some people have pointed out, you also got to look under the hemidiaphragm. That's my final check area. Look under the hemidiaphragms, make sure there's nothing abnormal. On this situation, we don't have something called a continuous air diaphragm sign. So generally speaking, you shouldn't have an interface between the cardiophrenic angles and the diaphragm, because they're almost equal in density. And if there is an increased contrast or fluid air between the two areas, then you're probably looking at pneumomediastinum. We don't have anything like that here. We don't have a continuous diaphragm sign, but as people have pointed out, there's a little tiny slit of air. Can everyone see that? If you just point in there, can you see that? Tiny slit of air just sitting on top of the liver. And so straight away, you've got to be thinking, this could be air under the hemidiaphragms. Yes, someone has said that it could be a normal post-operative appearance. Any sort of air within the abdomen could be a post-operative appearance, depending on when the operation was done. But if you've got someone who's come in and they've not had any surgery and they look like this, then you've got to be concerned there's some sort of gas-forming problem here. So either it could be a perforated intra-abdominal viscus, i.e. bowel, or it could be a gas-forming organism. And I've seen this kind of thing happen with emphysematous pyelonephritis, emphysematous cystitis, abscess formations that happen as a result of a perforated diverticulum and all that kind of thing. So yeah, it can be post-operative, but that's why the clinical history is so important with all of these kind of these situations.